Greetings, my wonderful students. I, Dr. Jyoti Vaibhavi, welcome you to today's lecture video on microcirculation. In the previous lecture video, we had learned about stalling forces and how they are balanced. So this lecture, we are going to study what happens when stalling forces are thrown out of balance and how edema occurs. These are the specific learning objectives. Even though they look simple, edema is a very important topic to learn. So, what is edema? Edema refers to the presence of excess fluid in the body tissues or body fluid compartments. Okay, based on which body fluid compartment there is excess fluid, it is divided into intracellular edema and extracellular edema. So, moving on to intracellular edema, let's see the causes. Three conditions are especially prone to cause intracellular swelling. They are hyponatremia, depression of metabolic systems, and lack of adequate nutrition to the cells. Let's learn one by one how each one of them can cause intracellular edema. So, when plasma sodium concentration is reduced more than few milliequivalents below the normal is around 145 milliequivalents per liter, 142. So when it is reduced less than 142 milliequivalents, a person is said to be having a hyponatremia. Okay, so now if you can see this diagram here, it shows the ionic composition of the major body fluid compartments. Okay, so this picture, this line is showing the intracellular fluid compartment. This is the interstitial fluid and this is the plasma ionic compositions. What I want you to see in this diagram is that the sodium which is there in the extracellular fluid compartment and here in the intracellular also it's there, but very less. Whereas in the extracellular and interstitial compartment, sodium is the major ion. Okay, that you have to keep in mind. Extracellular fluid contains sodium as the major ion. Okay, so why am I telling you this is that the plasma osmolarity, it's around 300 milliosmoles, or ECF osmolarity, is the major determinant of the osmolarity is the sodium. Because of its abundance and of course its attendant ions like chloride and bicarbonate, all this together are the major determinants of the ECF osmolality. So rough estimate of if I cannot measure the plasma osmolality for some reason, if I have to roughly tell that okay, plasma osmolality is normal or abnormal, I can just estimate the sodium concentration. So just by doubling the sodium concentration, I can tell you what is the plasma osmolality. If for example the the sodium concentration is 145 maybe, then if I double it, it is 290 milliosmoles. So it is a rough estimate of plasma osmolarity. So whenever the sodium ions are too much in the body, we can say that plasma osmolarity has become too much. It is more than 300, we can say. And when there is hyponatremia, we can very easily say that plasma osmolarity has reduced. Now, do you remember this picture here? We had done this experiment where we put the red blood cells in different tonic solutions, isotonic, hypotonic, and we saw what happened to the red blood cells. Yeah, so when we had put this red blood cells, you at this point you have to remember that osmolarity throughout the body, whatever is there inside the cell, the same osmolarity is there outside the cell. So that's how the equilibrium is managed. Okay, so now whenever the cell inside of the cell is 300 milliosmol and I take a solution with similar osmolarity and put it there, nothing happens, right? Now no change. Now what I do, I take the same RBC and put in a solution where the osmolarity is less than this. It is 200 milliosmoles, whereas the red blood cell osmolarity is 300. So now what happens, because the solute concentration is more in the RBC compared to the outside solution, the water, there is osmosis, all the water starts coming into the RBC and the RBC starts swelling. Okay, So same thing happens when we have hyponatremia. When we have natremia, the plasma osmolarity is reduced. Okay, but this cells, all the cells, intracellular compartment has the same osmolarity, but the plasma, ECF plasma osmolarity has reduced. So what happens now? Osmosis happens, and all the water from the ECF comes into the intracellular compartment like this, and there is intracellular edema. So we understood whenever there is a hyponatremia, there is intracellular edema. Okay, what about the other two causes? How does these causes intracellular edema? Let's take an example. Let's take any tissue in the body. Okay, so let's imagine blood flow to that tissue is decreased. Okay, so what happens? The delivery of oxygen and nutrients is reduced. So if the blood flow becomes too low to maintain normal tissue metabolism, so there is decreased ATP. When there is no metabolism, how will the currency of the body ATP produced? So that also is decreased. If ATP is not there, sodium potassium pump won't act. As we all know, sodium potassium pump is the very important pump in the body. So it utilizes ATP to keep the sodiums outside and potassium inside. And 25% of our body's metabolic energy is spent just to keep the sodium potassium pump active, right? So when sodium potassium pump is not working, what happens? In each cell there are some leaky channels which allows only sodium to come inside. Sodium leaky channel, some low sodium somehow come into the cell. So when it comes into the cell, sodium potassium pumps are at work, and they very promptly take away or push away all the sodium which is inside to outside and keep the sodium outside. Now what has happened? Sodium is leaking, but there is no sodium potassium pump to keep it outside, to push it outside. So what happens? So there is excess intracellular sodium. Whenever there is extra intracellular sodium, there is more solutes inside the cells compared to outside. So the water, osmosis of water into the cell happens. So sometimes this can increase the intracellular volume of a tissue area even to a degree, even of an entire ischemic leg, for example, 2 to 3 times normal. Okay, so that much osmosis occurs. So when the osmosis occurs, there is intracellular edema. So this is how depression of metabolic system or lack of adequate nutrition to the cells causes intracellular edema. Okay, so whenever the metabolism is decreased or whenever nutrition is not there, this important sodium potassium pump is not working. So excess sodium and osmosis of water into the cells and intracellular edema occurs. Okay, so now to summarize the concept so of intracellular edema, you have to remember this. So wherever the sodium went, the water was sure to go. So whichever compartment sodium goes, the water drags along. That's mainly because of the osmosis, but that is how you have to remember. Okay, so now let's move on to extracellular edema. Um, Usually, when clinicians and doctors refer to edema, then it is extracellular edema. I repeat, it is extracellular edema. Unless otherwise specified as intracellular edema, it's always extracellular edema. Okay, so edema also clinically can be defined as increase in the interstitial fluid volume. Okay, so why there is so much fluid accumulation in the interstitium in edema? We have learned in the previous class that there is stalling forces, lymphatics are working, interstitium is a gel, and all the interstitial fluid has negative pressure, and it has low compliance. In spite of that, how does the edema occur? So the basic concept you have to understand is that either arterial end is not working properly, or the venous end is not working properly, or the capillaries itself there might be damaged, or something wrong with the lymphatics. If one of this is not working, then edema occurs. For example, at the arterial end, severe arterial dilation happens. It leads to too much fluid, in which fluid, which in turn leads to too much hydrostatic pressure and too much filtration. Or for some reason, if venous system is blocked, maybe due to thrombus, then too less absorption and too much fluid in the interstitium, and interstitial fluid edema occurs. Or capillaries have become damaged, too much endothelial collapse, or endothelium itself is damaged, then also edema occurs, too much interstitial fluid. Everything is or everything is normal. Microcirculation is entirely fine, stalling forces is fine, but the lymphatics are blocked. Then whatever the little proteins that have been filtered, whatever the little fluid which was supposed to be taken back to the circulation by the lymphatics remains here, and there is interstitial edema. So this picture you should keep in mind whenever you have to analyze things. Okay. So extracellular edema occurs when there is excess fluid accumulation in the extracellular compartment, right? There are two general causes of extracellular edema: abnormal leakage of fluid from plasma to the interstitial spaces, or due to blockage of lymphatics um, here. Due to blockage of lymphatics, there is no return of extra fluid from interstitium into the circulation. Okay, so this is just a schematic diagram showing you the different compartments: interstitial fluid, plasma, capillary membrane, the lymphatics which takes back the interstitial fluid to the circulation. If this is not working, or there is too much filtration, any one of this causes extracellular edema. Among these two, what do you think is more important? Which is the one which is causing extracellular edema? Most important cause of causing extracellular edema. So among these two, it is this one. Okay. The most common clinical cause of interstitial fluid accumulation is excessive capillary fluid filtration. Yeah. What is it? Excessive capillary fluid filtration. Among these two, this is the most common clinical cause. So now we should analyze why there is excessive capillary filtration. What are the factors that increase capillary filtration? It's very simple. If we put mathematically, the rate of capillary filtration is given by this formula, where we get the by taking the product of net filtration pressure and capillary coefficient, we get the rate of capillary filtration pressure. So either of this, either this when it increases, or net filtration pressure when it increases, there is capillary filtration rate increases. Okay. Decrease also in the same place, and you should remember capillary filtration coefficient depends on the number of pores in the capillaries, number of capillary, and also the number of capillaries. So all this determines the capillary coefficient. So any one of this increases, there is increased capillary filtration. With this basics, let's move on to the causes of extracellular edema. A large number of conditions can cause fluid accumulation in the interstitial spaces by abnormal leaking of fluid from the capillaries, or by preventing lymphatics from returning to the interstitium, any of the two major causes. So these are the partial list of conditions that can cause extracellular fluid edema. So maybe due to increased capillary pressure, the conditions which causes increased capillary pressure, the conditions which causes decreased plasma proteins, or the conditions which causes increased capillary permeability, or the conditions which block the lymph return, all these causes extracellular edema. We'll cover each one of them. So increased capillary pressure and edema. Capillary pressure means increased capillary hydrostatic pressure. So as discussed earlier, the most sodium chloride added to the blood remains in the extracellular compartment, as we all know that. only small amount enters the cell. Therefore, in kidney diseases that compromise urinary excretion of salt and water, large amount of sodium and water are added to the extracellular fluid. We all know that whenever there is kidney disease, salt and water is not filtered properly and too much extracellular fluid volume is there. So, when there is too much fluid, what happens? Too much fluid is coming into the capillaries. There is increased capillary hydrostatic pressure and increased filtration, right? So, this is one of the reason why, due to kidney problems, kidney diseases, we have increased edema. And coming to high venous pressure and um, venous constriction, okay? So, in heart failure, the heart, especially heart failure, when we say there are different kinds of heart failure. There's just right heart failure, or there is left heart failure. Sometimes both the heart, right and left, are in failure, and we call it as congestive cardiac failure. This is a separate topic we shall be covering sometime sooner. uh, so let's talk about the right heart here. Right heart failure happens, the heart fails to pump blood. Okay, the heart is it cannot pump the blood into the pulmonary artery. All the blood which is coming from entire body to the venous circulation to the right atrium and right ventricle is just stored there. Right ventricle cannot pump. So what happens? There is raised venous pressure, and this venous pressure is reflected back into the venous system into the capillary pressure, causing increased capillary filtration. Okay, so this is one of the reason why heart failure causes increased edema, and whenever there is venous obstruction, okay, uh, maybe for any reason, maybe for thrombus or anything, when there is a venous obstruction, so the capillaries, whatever the in the capillaries, whatever the fluid is filtered from the arterial end into the interstitium, from the interstitium again it has to go back to the venous end of the capillaries, and it is reabsorbed back. If the venous end is blocked, okay, you imagine that diagram. If venous end is blocked, whatever the fluid is was filtered in the interstitium, it stays there. So that is how there is extra fluid in the interstitium, and there is interstitial edema. Whenever there is a venous obstruction, the fluid which is filtering, it is too much filtering, and also there is increased capillary pressure. Okay, then failure of the venous pumps. So if venous pumps fails to put back the all the venous blood into the right atrium, so the muscles and venous valves, all this plays a very important role in pumping the venous blood right from the lower extremities to the right to the heart. So whenever these pumps are in failure, all the venous blood which is pooled, which will cause a very huge venous pooling of blood, and in the capillaries they'll raise the capillary hydrostatic pressure. So then, coming to the arterial end, whenever there is excess body heat, there is the arterial end, there is dilatation of the arteries. So too much blood rushes into the capillaries whenever there's a excessive body heat, and there is more capillary fluid hydrostatic pressure, more filtration happening. And sympathetic system, you remember the components of the microcirculation? Remember, there is precapillary sphincter. After that, the meta-arterioles at the meta, there is precapillary sphincter. They constrict and relax and control the amount of fluid coming into the capillaries. Yeah, vasomotion. Yeah, it's sympathetic system. The capillary sphincters, they control them whenever there is insufficiency of this. So it is not well controlled, and too much blood flows into the arterial system. Okay, and vasodilator drugs, if you give some dilation, there is vasodilation, too much arteries are dilated, too much blood flows into the capillaries, too much capillary hydrostatic pressure increases. These are some of the causes, some of the conditions which causes increased capillary hydrostatic pressure leading to edema. Okay, so if I can summarize all this with this picture, so I want you to picturize this. Whenever there is a right heart failure, it cannot pump into this pulmonary artery, so all the blood is pooling here and pressure is increasing. It reflects in the venous system, which is again reflected in this capillary system. Hydrostatic pressure increases, the venous pressure is reflected here, and there is too much filtration into the interstitium. And whenever there is increased heat, or when you give a vasodilator drugs, or sympathetic system is not working properly, arterial dilatation happens and too much blood is coming into the capillaries, so too much capillary pressure increases. Okay, these are the reasons you have to remember. Or for some reason there is too much blood volume is increased because kidneys are not working properly or some reason, then there is increased capillary pressure. So I can put it in the flow chart. For any reason, venous obstruction, arterial dilatation, or right heart failure, or increased blood volume, there is increased capillary hydrostatic pressure, which leads to increased filtration, which leads to increased lymphatic flow. So here I want to mention you that these lymphatics which are there, they play a very important role. They are like a safeguard for us. They are the cards which are helping us keep the uh, microcirculation, and they are safety factor. They prevent edema. So whenever there is an increased fluid is coming into the interstitium, these lymphatics don't keep quiet. They work very hard. If they work 10 to 50 times more than what they used to work, to pump out all the extra fluid into the circulation. Yes, but they do their best so that there is no extra fluid in the interstitial edema. But when the lymphatic system also gets overwhelmed with the amount of fluid in the interstitium, then edema occurs. This is a very important safety factor which lymphatics play a role. So whenever the lymphatics is unable to pump out all the fluid, even it is working 50 times harder, then only edema occurs. Okay. Then one more very important cause is decreased capillary oncotic pressure. Okay. Capillary oncotic pressure, as we know, it's because of the plasma proteins. What are the plasma proteins, major plasma proteins in the body? Yeah, it is albumin, globulin, and fibrinogen. Among that, albumin is the most important and most abundant compared to these two. Fibrinogen is the smallest one. Okay. So, a reduction in the plasma concentration of proteins, either because of failure to produce normal amounts of proteins, or sometimes the protein is produced normally but there's too much leakage happening. So either production problem is there or leakage problem is there. Then colloid osmotic pressure of the capillary decreases, right? So either proteins are lost or proteins are not produced at all. This leads to uh, so we if you remember the stalling forces, the major force which was the major inward force of the stalling force was this capillary oncotic pressure. If the major inward force is not there, there is too much filtration happening and reabsorption is very less, so there is too much fluid in the interstitium. Okay, so one of the most important cause of decreased protein concentration is loss of proteins in the urine, especially in the kidney diseases like nephrotic syndrome. Okay, so there is loss of proteins because glomeruli are damaged, causing the membranes to become leaky to the plasma proteins, allowing a large quantity of proteins to pass in the urine. So when this loss exceeds the ability of the body to synthesize proteins, a reduction in the plasma protein concentration occurs. Okay, when the plasma protein concentration is reduced below 2.5 gram per 100 ml, then we say that there is hypoproteinemia and there is decreased capillary oncotic pressure, which leads to more fluid accumulation in the interstitium. So Also, in conditions like burns and wounds, endothelial damage or endothelial gaps are increased, then there is too much loss of proteins from the skins and capillaries. Okay, and failure to produce protein. Cirrhosis of liver is another condition that causes a reduction in plasma protein concentration. So, what is this cirrhosis? Cirrhosis means development of large amount of fibrous tissue among the liver parenchymal cells. One result of which is failure of the cells to produce sufficient plasma proteins, leading to decreased plasma colloid osmotic pressure and generalized edema that goes with this condition. So, whenever there is a liver cirrhosis, there is hypoproteinemia. Hypoproteinemia, whenever it occurs, it causes generalized edema, means all over the bodies there is edema. Okay, uh, or protein energy malnutrition, where um, the malnutrition there is a if a person has malnutrition and protein is not sufficiently either manufactured or taken are able to synthesize, then there is accumulation of fluid. You can see in a kwashiorkor baby there is edema, you can see, because of this. Okay, there is decreased capillary oncotic pressure, more fluid in the interstitium, leading to interstitial increased interstitial fluid, leading to edema. So these are the reasons why decreased capillary oncotic pressure causes edema. Okay, then increased permeability of the capillary walls. So when there is permeability increases, it allows more plasma proteins than usual to whatever is there in the capillary fluids, plasma, everything goes inside the interstitium, because endothelial cells are very much permeable to everything inside the capillaries, the plasma, the proteins, everything is filtered out than usual to pass from the plasma into the surrounding interstitial fluid. For example, histamine. This histamine, which is there during immune reaction, it causes widening of the capillary pores during tissue injury or allergic injury. Okay, hence there is more fluid coming into the interstitium. Interstitial fluid pressure increases. Okay, and also because proteins are coming into the interstitium, it drags all the fluid in and holds more fluid in the interstitium. Okay, also in certain conditions, burns and all this, whenever there is increased capillary permeability, uh, more fluid is coming into the interstitium. Along with that, if proteins also come, it leads to more accumulation of fluid in the interstitium. And coming to systemic capillary leak syndrome. Okay, so this is the condition where Walter Bredinen, middle-aged man, suddenly suffered from this systemic capillary leak syndrome, and was when he was affected. Okay, this picture. So what happens in this condition? It is a genetically very rare disorder. Exam point of view, this is not at all important, but as a mm, nice way to study capillaries and its function, I had just posted you this case. So here what happens in the systemic capillary leak syndrome or Clarkson syndrome, very rare genetic disorder where capillaries, what they are the endothelial capillary, okay, they separate from each other, that also very transiently. Okay, they separate for 1 week or 2 week and they again regenerate back, reversing. They are self-reversing episodes of endothelial gaps. Okay, capillary permeability increases because the endothelium gap increases, and they self-repair themselves after a few days and it will be fine. So whatever fluid is coming into the capillary system, it just leaks through the interstitium all over the body, so much that the entire fluid will be present in the interstitium. You can see it is unrecognizable at all. So increased endothelial gaps leads to increased fluid and plasma protein filtration. Too much fluid in the interstitial fluid, that it becomes positive. When it becomes positive, it becomes high compliance, and too much water is coming into the interstitium. Volume increases like anything, like liters together are there in the interstitium, maybe 20, 30, 40 liters like that, and there is generalized edema, very dangerous kind of edema occurs. Okay, this is about the case which we had discussed um, before microcirculation class. And the last reason is blockage of lymph return. Whenever lymph nodes are blocked or lymph vessels are blocked, then whatever the interstitium, whatever the little proteins have come to the interstitium, little fluid has come into the interstitium which cannot be reabsorbed back in the venous system, remains in the interstitium because lymphatics are not working. For example, filariasis. This is a case of filariasis. Okay, so what is this filariasis? Okay, it's nothing but blockage. This person is infected by a filaria nematode called as Eukaryotic bancrofti. Okay, you will study this in second year of MBBS. These are very microscopic thread-like worms. Okay, the adult worms, they love to live in the human lymphatic system, and they spread from one person to another through mosquito infection. So, people with filaria infections can suffer from severe lymphedema. So, whenever the edema occurs due to lymphatic blockage, it's called as lymphedema. So, this filarial infection occurred people, they suffer from lymphedema. And elephantiasis in men, sometimes the men will have swelling of the scrotum also, which is called as hydrocele. Also, when in certain types of cancer, lymphatic vessels are destroyed, or surgery, or absence of lymphatic vessels, so there is accumulation of small proteins in the interstitium. These small proteins which are staying in the interstitium, they drag the fluid to themselves, they hold the fluid to themselves, and there is increased colloid osmotic pressure. It actually reabsorbs the fluid from the capillary, and there is increased interstitial fluid volume in lymphedema. So when we talk about lymphedema, we have to definitely know what is pitting and non-pitting edema. What is pitting and non-pitting edema? How to elicit it? To elicit pitting, one can press the thumb like this against the tissue area and push the fluid out of the area. So when you remove the thumb, okay, a pit is left in the skin for a few seconds until the fluid flows back and the surrounding, and again the pit is gone. So if when you press it, if a pit formation is there, it is called as pitting edema. When you press, this pit formation is not there, it is called as non-pitting edema. Okay. Now that we know how to elicit pitting and non-pitting edema, why is it important to elicit pitting and non-pitting edema? What does it add to our clinical diagnosis? Okay, to understand this, you have to understand this case scenarios. You take this patient A and this is patient B. Okay, let's look at this patient A. This patient A has undergone radical mastectomy, means breast operation has happened and they have removed the breast tissue along with a little bit of lymph node and lymph tissues, due to which the drainage of the lymphatics is not working in this arm. Okay, here what happens, the blood is coming through the arterial system, okay, and capillaries are working fine, lymphatics vein also is working fine, reabsorption also is happening, stalling forces is fine, but the lymphatics is not working because radical mastectomy has happened and there is no lymphatics working in this arm. So whatever the fluid and proteins are left behind in the interstitium, they are holding the water and causing more and more osmosis, and more fluid is left behind. Over a months and years, this over some few months, this edema has occurred. Okay, only in this arm because lymphedema has occurred. Okay, this is about this patient. Let's come to patient B. Okay, here this patient has right leg edema. It is due to deep vein thrombosis in this person. The veins which are there in this person right leg have become thrombosed. There is thrombosis and there is thrombosis of the vein, and that's why the venous system is not working properly. Okay, so here arterial system is fine, capillaries are fine, but venous drainage is not happening, venous reabsorption is not happening. Because of that, hydrostatic pressure increases, more filtration is occurring, and more fluid is drained into the interstitial fluid, right? Here, due to lymphatic blockage, the proteins which are there, they are holding the water. Here, due to venous blockage, more water has come here. Now let's elicit the pitting, sign of pitting. Okay, if I do a pitting, elicit the pitting edema here, what happens? Or here I apply, what happens? What do you think? So here there are proteins. Here there are, they are just interstitium has just the interstitial fluid. What happens? What do you think? So here when I elicit pitting edema, it is non-pitting. Lymphedema is non-pitting. Okay. So here when you elicit, it is pitting. Why it is not pitting here? When you put pressure, you cannot displace the proteins which are holding the water. As interstitium has got clotted, interstitium has that small proteins which has filtered, fibrinogen is able to clot the interstitium. It is clotted with that, and protein which is holding the water, you cannot separate that water from the protein. So when you elicit pitting here, you cannot displace the water here because proteins are holding them here. Okay, but when you elicit here, put pressure here, the fluid where they are present in the interstitium, you remember there are free fluid spaces, there are rivulets and all that. So those free fluid spaces contain all this water. So whenever you put a pressure here in this patient, when you put a pressure, the thumb is able to fluid which is mostly in the free fluid space, which will spread across. Okay, they will make this brush piles, proteoglycans, collagen fibers to push across, and then this depression happens. The fluid will displace the proteoglycans and collagen, and there is a depression there. After sometimes the proteoglycans and collagen come back in the interstitium. That's why all those conditions which causes edema due to interstitial proteins in the interstitium, okay, that due to interstitial colloid osmotic pressure or lymphatic blockage, this non-pitting. Whereas pitting is due to increased hydrostatic pressure, increased capillary permeability, where more fluid is in the free fluid places of the interstitium. Why is this important? Why is it important to know that whether it is pitting or non-pitting edema? For if it is a pitting edema, as you know, there is just fluid, extra fluid in the interstitium. When we give a diuretic, the kidney will suck out all those fluid from the interstitium and the fluid level might become normal. But if you give a diuretic in this patient, non-pitting edema, it cannot pull the water because water is held by the proteins. So this is very important clinically. That's why we elicit pitting and non-pitting edema, so we know what is the cause of it. Okay, and a word about localized and generalized edema. When edema is confined to a tissue or an organ or part of hand or limb, it is called as localized edema. When it's present all over the body, it is called as anasarca. Generalized edema, majority of when you come to generalized edema, majority of the patient will have a cardiac, renal, hepatic or nutritional disorder. Okay, it's very important when a generalized edema patient comes to you, you have to rule out all this. Cardiac edema, whenever there's a right heart failure, for example, the venous pressure increases in all over the capillaries, isn't it? Not just the one or two capillaries, all over the system, all over the capillaries in the body, there is capillary hydrostatic pressure increases, there is edema. Whenever there is a renal cause, too much extracellular volume of the fluid volume increases and there is edema. Hepatic cirrhosis, when there is decreased plasma protein, there is edema. So like that, these are the causes which causes edema entire body, to the entire body. So whenever you have a generalized edema, the differential diagnosis of it should be directed towards identifying the cause, not just treating the edema. So you should understand, so whether it is localized or generalized, and your diagnosis and treatment should be based on that. And a word about edema in potential spaces. What are these potential spaces? Nothing but pleural cavity, pericardial cavity, peritoneal cavity, where All these spaces have surfaces that almost touch each other, and they have a viscous proteinaceous fluid in between the membranes of this, right? So whenever the subcutaneous tissue there is edema, even these get edema, even these spaces there is increased fluid and there is edema. So whenever this potential spaces there is extra fluid, is example in the pericardial, this one, fluid increases, we call it as pericardial effusion, pleural effusion. So we call it as effusion. Okay. uh, Even they have a lymphatic drainage. Whenever lymphatic blockage is there, you get effusion. Okay, so let's summarize what all we studied today. A very important topic. So we studied what is edema, we learned what are the causes of intracellular edema, we learned extracellular edema, all the causes, increased capillary hydrostatic pressure, decreased capillary oncotic pressure, why there is increased capillary permeability, blockage of lymph return, uh, what is the pitting and non-pitting edema, and how is it helpful, and what is generalized and localized edema, what is effusion. So this was about edema, and these are the references. So this completes the microcirculation chapter. Please go through the videos and refer student guidance for better understanding. Thank you all for patient watching.